Hello and good afternoon. My name is Aaron Williams and I'm a fifth-year general surgery resident at the University of Michigan. I'd like to thank the STSA for the opportunity to present here today. Our work highlights comparing long-term patient-reported outcomes between open and robotic transhiatal esophagectomy for esophageal cancer. We do have several disclosures, as you can see here. Esophagectomy continues to be the primary treatment modality for patients with local regional esophageal cancer. Within the last decade, minimally invasive esophagectomy, or MIE, has grown and conferred many benefits over open esophagectomy. These include decreased hospital stay, morbidity, and mortality. These benefits, however, have largely been shown for either Lewis and three-hole approaches. Now, patient-reported outcomes and quality of life have also become important metrics. MIE has been shown to provide multiple benefits compared to open esophagectomy, including decreased pain and overall better functional status. Again, these benefits have largely been observed comparing open and MIE, IVR, and three-hole approaches. Now, although comparing patient-reported outcomes has become popular, little is known regarding comparing open and MIE-THE approaches. Therefore, the aim of this study was to compare long-term patient-reported outcomes involving quality of life and fear of recurrence for patients undergoing open and robotic THE for esophageal cancer. Now, to answer this question, we included patients with pathologically or clinically confirmed stage 1, 2, and 3 esophageal cancer undergoing open or robotic THE from 2014 to 2018 at a single high-volume center. Open or robotic THE approach was based on surgeon preference, and all surgeons included had greater than 50 esophagectomies. Regardless of approach, all patients underwent esophagectomy with a CEG anastomosis, pyloromyotomy, and J-tube placement. All patients then underwent a standard postoperative pathway. Patients were then assessed prospectively using both quality of life and fear of recurrence questionnaires. The QLQC30 is a 30-item questionnaire evaluating 5 functional domains of quality of life, function scales, and symptoms, while the OES18 is an 18-item questionnaire that evaluates esophageal cancer-associated symptoms and treatment-related side effects. The fear of recurrence survey measures a patient's anxiety and depression. Questionnaires were administered at baseline as well as 1, 6, and 12 months post-operation. Scores then underwent linear transformation, with higher function scores being better and lower symptom scores being better. Summary scores were also performed. A linear effects model was then used with patients with at least one baseline and one postoperative survey. Time, baseline, demographics, characteristics, and complications were adjusted for. We also looked at secondary outcomes, including patient demographics and perioperative outcomes. In terms of results, there were 212 patients in the open THE group compared to 97 in the robotic THE group. There was a steady decline in survey participation at each time point after surgery to about 40 to 45% up to 12 months. However, these were not significantly different between groups. Patient demographics and characteristics were also compared. There were no significant differences in age, sex, BMI, race, ASA class, preoperative comorbidities, and prior cardiothoracic surgery between groups. There were no significant differences in tumor location, pathologic staging, types of esophageal cancer, and neoadjuvant therapy between groups. As I mentioned before, the QLQC30 is a 30-item questionnaire evaluating 5 functional domains of quality of life, function scales, and symptoms. Similar to other studies, we sought to evaluate global health, physical and role functioning, and pain. We found that there were no significant differences in these metrics between groups at any time points. The remaining metrics on the QLQC30 had similar findings. There were also no significant differences in additional function scores and symptom subscores or summary scores between groups at any time point. Again, the OES18 is an 18-item questionnaire that evaluates a patient's esophageal cancer-associated symptoms and treatment-related side effects. We found that there were no significant differences in symptom subscores, including things such as dysphagia, pain, eating, choking, and trouble with saliva or cough, or summary scores between groups at any time point. The fear of recurrence survey measures a patient's anxiety and depression. We found that there were also no significant differences in these subscores and summary scores between groups at any time point. In terms of perioperative outcomes, the robotic THE patients had significantly decreased length of stay and a higher number of lymph nodes harvested during surgery compared to the open THE group. There were no significant differences, however, in the incidence of any postoperative event, patient disposition, 30-day readmission, reoperation, mortality, discharge status, and need for adjuvant therapy. There was a trend towards lower rates of reoperation with the robotic THE group. At the time of discharge, however, the robotic THE group had a significantly lower number of patients prescribed opiates for pain control. In terms of specific complications, the robotic THE group had lower rates of ileus compared to the open THE group. However, there were no significant differences in cardiac or pulmonary complications, DVT, anastomotic leak, outlet obstruction, or chyle leak between groups. Although this study shows no difference in long-term patient-reported outcomes for patients undergoing robotic and open THE, it does have several limitations. The first being, this is a single-center study. We also recognize that there has been a change in minimizing opiate prescriptions and promotion of enhanced recovery protocols in recent years. We were also unable to account for surgeon-specific factors, techniques, and patient perception. Now, despite these limitations, this is the largest comparison of robotic versus open THEs comparing clinical outcomes and the only study comparing patient-reported outcomes between these two approaches. In conclusion, this study highlights that there were no clear patient-reported benefits with robotic versus open THE, which is in contrast to other types of MIE studies. However, we did observe that the robotic THE conferred many benefits in perioperative outcomes. As such, other factors such as these outcomes and surgeon experience and comfort may be more important determinants for selecting open versus robotic approaches for THE compared to patient-reported outcomes. We also recognize that a broader evaluation of patient-reported outcomes is also needed to further determine the utility of these metrics. Thank you, and I'd be happy to take any questions.